Welcome to Blue Collar ICs, the podcast that pulls back the curtain on interventional cardiology. Hosted by Jordy Culotta, Bill Dixon, Brian Brown, and Todd Flor, this is where real doctors talk real work. From the cath lab to complex cases, new devices, and hard-earned lessons, these are the conversations that don't happen in textbooks. No hype, no fluff. Just experience, expertise, and straight talk. Welcome to the conversation. This is Blue Collar ICs.
Welcome in to another edition of Blue Collar ICs as we get going this week with a very interesting topic. Looking forward to our topic this week, intracoronary imaging. We're going to talk about it with Dr. Brian Brown. We're going to talk about it with Dr. Aaron Gopal, who is beautifully dressed tonight in the purple and gold. Home of Lane Kiffin and Will Wade, Kim Mulkey and crew. Hate everybody. Bring all the hate on. Dr. Bill Dixon, and of course, our CEO, Todd Flor, who is checking in from Charleston, South Carolina Airport, as he has just landed from another conference. And before we jump in, everybody, to tonight's topic, which is very interesting, we had a chance to all be in the same place last week, which is very rare for all of us as we're jumping all over the world and all over the time, at NCVH. Obviously, an incredible conference. I believe it was the 26th year for Dr. Craig Walker and his crew. 27th. I'm sorry, 27th year. 27th year. Down in New Orleans, we were at the Roosevelt. Todd, I'll start with you because I know this means a lot to you, this conference, and it means a lot to all of us. But just what last week was like.
It was fantastic as usual. I think to me, it's always amazing to be around and see the team that Dr. Walker has built and the legacy he's built through Cardiovascular Institute of the South, his former fellows, and his leadership team. And just the fact that the meeting is so vibrant and robust and well attended every year is just a huge testament to the legacy and his ability to scale. Great content, great people, great friends. It's just always a great experience.
Dr. Brown,
you're glad to be part of it.
Absolutely. Dr. Brown, you did live cases once again from the conference this year. Talk about how your relationship with the conference NCVH and you're really, I've only been there for 2 years, but I have felt your presence grow within that conference. What is it about New Orleans and NCVH that brings out all of your attention?
There's so many things that can be said right now. Before I get into that, though, one, I love that we're bringing the episode in with talking about NCVH. Now, one caveat: we all were there, but not at the same time.
That's right.
One Bill Dixon had left one day early because he apparently doesn't like a good time.
I got there one day early.
At the same time. That's true. Now, I want to
They don't have enough bourbon for both of us.
Yes. Thank you, sir. So I want to give an introduction to my partner who I met at NCBH on the floor with the vendors. I was down there with Matthew Finn, a buddy of mine that works down there. He's from down there. And he said, "Hey, I want you to meet our fellow Aaron. Aaron's looking for a job." And I said, "Hey, my name's Brian." And he said, "My mom lives in Charlotte." I said, "Perfect. Come work with us." And that was it. And now Aaron works here, but he's excellent. And I want him to introduce himself.
Yeah. So as you guys know, my name is Aaron Gopal. I trained under Dr. Walker about 4 years ago now. Probably the best year of training I ever had. We did a bunch of stuff, and just like Brian was saying, I met him at that NCVH, the 23rd NCVH. He was doing live cases and talking, and he knew I was looking for a job in the area. And I still remember that night. We just hung out and drank and just had a good time, and had a pretty quick interview. But I kind of knew I wanted to stay here when I met him because I knew I had a good colleague and a good friend for a long time. What's not to love about Spartanburg, though? There's a lot of disease.
Bird, baby.
The bird. A lot of disease.
I have to say the airport is awesome there. So
It's an excellent airport. My friend is currently like the commissioner of it, and that was the original site of Talladega,
Wow.
until Roger Milliken decided that would not be ideal because all the people would have this place to go on the weekend. It would be ideal if they maybe were focused on getting back to work on Monday. Great airport. So that was my first year doing live cases, and I was super nervous about it, and it was a really big deal. And this is now my 4th year, and I'm growing into it a little bit, but I'm still very nervous. And since that year, since Aaron joined the practice, we have done the cases together, and it is just a lot of fun to work together. I don't know if it's as much fun for you as it is for me, but I love knowing that I can chat for a little bit and let you do incredible work, and you can chat and then I can go to work. But what do you think about doing it together? I love it.
No, I really enjoy it. It really allows us to kind of speak. Of course, Brian does most of the speaking. He's a better talker. But it also allows us to collaborate, especially on treatment. There are many times that we'll differ, and he'll ask me what I want to do, and he'll say, I think we do this instead, and I say, all right, let's do it. And it allows for a little bit more creativity with regards to treating these patients.
It's very rare in your career that you actually get to work with another colleague during a case. That's not common.
Yeah, it's pretty relaxing when you have another operator with you. And if you're the second guy, you can think so much more clearly when you're not on the hook. You come up with great ideas. It's a lot of fun.
Now I want to take you to Bill Dixon, who was there with Jordy and with Todd, bringing the beautiful merchandise that Todd prepared, the trucker hats and the scrub caps. Bill, why don't you tell us about your experience with that?
With what? The hats?
Yeah.
No, we decided we needed some swag. Todd's going to get one out. I think there's nothing more blue collar than a trucker hat. And,
yeah, we got that.
Our buddy Bob Spanos sent a picture of him catching a massive tarpon down in Tampa wearing the hat. And then from R3, Nicole Schwartz sent me a picture. And so that's the thing now. Now people are going to want the hat, and they're going to want to take pictures of them catching fish with a hat. We have scrub caps, and anyway, I think that'll be a thing. So NCVH was great. One thing I like about it, it felt intimate. It's small enough that it's not some massive impersonal kind of meeting. And you kind of see people there year after year, and you really enjoy it, and you enjoy the social time. So you did your cases last week. Are they out of the hospital yet, or are they still there? Or
we did them at our office. They all must be frame day, safe and sound. Thank you.
All right. So yeah, NCVH was great. And we'll all be there next year again. So, Jordy, do you want to introduce the topic for tonight that we're going to talk about?
Yes, absolutely. As we mentioned when we were coming into tonight's episode, which reminder, make sure if you have not already done it, subscribe wherever you are listening to us, anywhere you can get this podcast, anywhere you are listening, make sure follow, join along, subscribe to this so you can be kept up with the content each and every week that we put it out. We're very excited about what's going on with Blue Collar ICs and what the future looks like with Blue Collar ICs. So we appreciate you listening. We appreciate you being here and really kind of joining us for the journey and the growth, which we are expecting over the next couple of weeks and hopefully into some years. Tonight, we will be talking about intracoronary imaging, which is a very interesting topic. And Dr. Brown, we will start with you on just your feeling here. I know this is a topic that we were talking about before we came on through our text chain that we were all looking forward to.
Great. Well, there are currently two main types of intracoronary imaging. One is called IVUS, intravascular ultrasound. The next product, OCT, optical coherence tomography, and they show you the inside of the vessel in a new way that angiography doesn't show you. What I like about tonight's podcast is that we have Bill, who graduated, let's say, approximately a decade before me, and Aaron, who graduated approximately a decade before me. So we So we have 20 years spread. And that's interesting because I think that the way we all practice is actually very attuned with how we were trained. So I remember using OCT in my general fellowship, but not very often. And I remember using some IVUS. But then when I went to Brown, it was very angiography driven by people that have been doing it for a very, very long time. And so we were taught terms like pig in a python, i.e., step
Still use that.
step down. And the reason for that is the stent takes up a portion of the lumen. And so these attendings that are teaching us were back in the days before stents even existed and talking about the difference of a POBA result versus a stent result. Whereas my entire training was stent related, a POBA result was almost never happening, which is kind of interesting as we move into juggling balloons, but we're not into that tonight. And so one thing that stuck with me with one of my attendings that was not about imaging, but was about flexibility, was regarding access. Giorgio Gemelli at University of Wisconsin told me, don't be a fundamentalist. All access points are good access points. Get to know them all. And I think that has some corollaries to this. So from here, do we want to go to Bill or to Aaron to talk about their experience with intracoronary imaging? Then definitely back to me, by the way.
So I like the term dogmatist. You be a dogmatist. Be a pragmatist.
Aaron, how do you use intravascular imaging in the coronaries and the periphery in your practice on a daily basis?
So I think I'll echo your sentiment. I do think differences in practice have a lot to do with training, and the differences are pretty evident, even amongst our senior partners with regards to imaging use. I'm not going to say that I'm a zealot for imaging by any means. There are plenty of times where I'll just use angiography alone, both in the periphery and in the coronaries, but I do tend to use it more frequently than some of my senior colleagues. And part of that is because of how I was trained. We had access to both IVUS and OCT during training. And when I was in Florida, we were a pretty heavy OCT hospital. And with Dr. Walker and his fellowship, we used a lot of IVUS. So I got pretty facile with both. And it doesn't add a whole heck of a lot of time in my workflow. And I think all of those factors play a role in its use, between physician to physician.
Caveat, coronary versus peripheral, adding time to your workflow, and a pullback that is manual versus on a sled.
That's I agree. But I would say at most it should only add a couple minutes to the case.
All right, so we're gonna go back in time a little bit. So I was at Duke 2001 to 2002. In the late 90s in San Antonio, there's a guy named Steve Bailey, who is a very well-known cardiologist. He actually did IR and then did cardiology after that. And I can remember in 2000 rotating with him, and he was using IVUS for every case. And if he saw a bunch of calcium, he would do rotablator first. And if he didn't, he wouldn't. He would just do predilate. But I don't remember doing any. Actually, I guess we must have done IVUS at Duke because we were also using the very first pressure wire called Ratty wire. And we say, if you want to fix it, do IVUS. If you want to leave it alone, do physiology, do the pressure wire. And those are two very different ways of trying to determine if a lesion is obstructive or not. But we did not use it routinely. But the way we did every case at Duke, we almost always predilated. After predilation, we gave intracoronary nitro every time to maximally dilate the vessel to make sure we had a good idea of how big is this vessel really. And then we would put the stent in, and I don't remember what pressures we were using. And then we go post-dilate, typically to high pressure, and that's the way we did all our cases. So I was trained without IVUS. I am incredibly comfortable doing things with angiography. I think as time has passed, especially a lot of the academic places, they're training fellows to use IVUS routinely. Over time, you kind of have, you mentioned the word zealot, and I'll use the word zealot. There are imaging zealots who think you can't be doing good PCI if you're not imaging every case. That's what I have a problem with. I'm not anti-imaging. Now, one question to ask, when do I use imaging? I don't use it very much. I use it if I'm not sure what's going on. I use it if it's going to change my plan. So I don't use it so I can say that I used it. The goal
What percentage of the time, Dr. Dixon, do you think you use imaging?
And there's, maybe it's just me, but so there have been great studies that show that people that get PCI with IVUS have better outcomes long term. Now I think a majority of those good outcomes are related to appropriate stent deployment. And that's kind of what makes the difference. And with stents, you can have what's called malapposition, where the stent's not all the way touching the wall of the vessel. And you can have under expansion, where the stent has a divot in it or something like that. Those two are very different. We probably get away with malapposition all the time because we have really good stents. And even in trials, what they consider optimal apposition is at least 90% of the lumen diameter area. So you could get away with malapposition as long as it's not a 2.5 stent in a 4.0 vessel. Stent under expansion is a different problem. Now, I think I'm pretty good at seeing stents on angiography and fluoro. But the guidelines, what's made it into the guidelines is you should use imaging when you're doing something complex, like left main, bifurcations, calcified lesions, CTOs. But what's happened, and a lot of it is industry marketing, there's been this push to use it every case, and not just at the end to make sure your stent's well opposed and well expanded, but oh, well, if you don't image first, you have no idea how you're going to open this vessel. Oh my gosh, I need to look because I've got a bunch of tools. If I don't image, I don't know whether to do atherectomy or whether to do a balloon or a non-compliant balloon or a cutting balloon. So they want you to image pre, then they want you to do a treatment like a balloon or a cutting balloon. Then they want you to image again to see if what you did worked. And then you do your stent and you finish, they want you to image again. So, the companies, they have these mantras, see, treat, verify, define, guide. And I think a ton of it is marketing, but I feel like there's been this message that if you're not doing routine imaging, you're not doing good PCI. And I have a problem with that. And so what I tell people, don't critique the way I do it, critique my outcomes. And I'll put my outcomes against anybody. So there are times when I'm not sure. There are trials. There's a trial that they did, and they said 70% of the people in the trial changed what they were going to do after imaging, 75%. So some guy went online and said, if my loved one is at a hospital that doesn't do routine imaging for PCI, I don't want them treated at that hospital. So I couldn't let that go. So I said, well, if my loved one's at a hospital where the operator's wrong 75% of the time, I don't want them treated there. So I'm not anti-imaging. I think there's absolutely a role for it, especially if we start looking at DCBs without stents. I think imaging is critical. I'd actually prefer OCT for that because I think it gives you better definition. But those are my 2 cents. But I've been looking forward to this. I mainly want to say for people that think you're doing bad PCI, if you don't IVUS, you can kiss my ass because that's not it.
It's your platform, Bill.
Bill, it sounds like you haven't really thought about this much. It's kind of
Well, it's almost like, when people ask you, well, do you image routinely? And I'm like, no, it's like, they're like the disappointed dad if they find out you don't image routinely. I mean, or they'll say, well, what'd the IVUS show? So I don't know. I didn't IVUS. I just fixed it.
So
the other stuff is crazy. Like, okay, calcium, not just is it calcified, but is it less than 180 degrees of arc or is it 270 degrees of arc? I will say 90% of lesions we can get open with a balloon, period. It's the other 10% that are more complex, and then you got to figure stuff out. But I think I'm concerned people coming out of training are completely paralyzed because they don't know what to do without imaging. And a bunch of it's just mental masturbation. Most lesions you can open with a balloon. You really can't. But anyway.
Hey, Bill, what
for a long time.
I've got a question. Do you think there's a connection between the drop in DES prices and the increased
focus on imaging by companies?
Yeah,
Or
because
is
they
it,
get
or
paid.
is,
IVUS still reimburses and DSs don't for those companies. Absolutely. Are you kidding
Yeah.
me?
So, oh, and the other thing, in addition, is all the freaking virtue signaling about imaging, right? I'm not doing PCI, I'm doing IVUS guided PCI. And they put that in the report. In every case, there's even beyond that real time IVUS guided PCI. That's called RTIG, as opposed to offline IVUS guided. I'm not sure what that is. So IVUS isn't the goal of a procedure. The goal of procedure is not to do IVUS. The goal is to do optimal PCI. So if you use IVUS to do that, great. If you're a good angiographer, I'm going to stop talking, but I want to come back to the two trials that were at that presented at ACC about IVUS.
All right. So I grew up with imaging, not as much as Aaron did, but I echo Bill's thoughts on essentially when I have a question, say I've placed a stent. I remember the trials, they essentially led to longer stents. The idea is landing to healthy, and that stuck with me. And so if I land a stent and I'm looking at the distal edge and the proximal edge, and I'm optimizing the proximal edge because the stent is generally going to be smaller distally, so I pick that stent and make it larger. If I have a question, I'll image because it just makes sense because we do same-day PCI so much. So I'll throw it on the OCT, and I'll say, no, the distal edge looks perfectly fine. I feel safe with this patient going home. But back to Bill's point, it's when I have a question. If I don't have a question about it, then I'm not doing it. It's when I can't see on angiography that I pull out imaging and I decide I need this to see what I'm doing because I cannot see what I need to do to make a decision to do this PCI. If I can see what I'm going to do and I know what I'm going to do, then I'm going to do it. Another great example would be like an osteo left main. For that to be class 1 to me is a little much, right? Most left mains are generally 4O vessels. There's some that are a little bigger. There's some that are a little smaller. You can generally see it. But the point is you can direct stent the majority of osteo left mains unless they're ultra calcified. And then you can optimize it afterward if you need to based on what it looks like. I'll tell you a story about someone that's a current CMO of a company in the United States for cardiology. I was at a dinner and I was showing him a cool OCT case. And this case was an NSTEMI, but there was really no culprit. But I saw this linear line in the proximal ID, just a line right through the vessel. And I kept taking different images and I just couldn't tell what was going on. I threw OCT down, but before I threw OCT down, I put the wire in. It was curling up. What was it curling up in? It was curling up in an empty plaque that was past the narrowing. So then I wired through the vessel, did the OCT, and it showed that the lumen was quite small, but there was an empty plaque that had gone beyond that created this linear artifact. I thought it was neat because it answered the question. Here's what happened. And the reply to me was, do they reimburse for intracoronary imaging? I was like, I think so. I said, but that's not the point. The point is it gave me the answer that I couldn't find on angiography. Aaron?
I'm going to let Aaron talk in just a second because he's our guest. But I had a case that I'm showing this weekend at a meeting. A partner did a good PCI of a distal circ. And then an hour later, the guy had tombstones, chest pain, and my partner was in another case, and I was on call, so I had to get stuck with it. So I'm expecting to find a thrombosed stent, and I didn't. And it took a little while to figure out what looked abnormal, but this was a fairly distal stent, but a majority of the circ, it just looked funny. It looked kind of like spasm, but why would you be getting spasm in this large 4O vessel? And it just kept bothering me. It just didn't look right. And I don't know why it looked the way it did. So I did IVUS, and the guy had this long intramural hematoma that was circumferential. So that completely made the case. I stented the rest of the vessel. But that's an example. So Aaron, what's your experience?
No, I agree with your statements. I know they recently changed the guidelines. They upped it from class 2A to class 1, and a lot of that was from some more contemporary data in 2023 that showed some differences in target vessel failure, which is the new outcomes measure they're using in a lot of these interventional trials, looking at either target vessel revascularization, MI, or cardiac death. And a lot of what was driven, which is what Bill was saying, was with target vessel revascularization. There was a nice meta-analysis that was published by Greg Stone, and that was the first time that they had shown a statistically significant reduction in all-cause mortality and cardiac death. But when we're talking about absolute numbers, we're talking about percentage points. I do think if you were to stratify based on operator experience, like Bill was saying, people that have been doing this for a long time and are really used to looking at angiography and understanding vessel sizes and not putting 2.5 stents in the left main, like Brian was saying, I think you can achieve very similar outcomes. But when there's questions, with regards to post-intervention imaging, or, you're not entirely sure what something is, I think that's where imaging is really helpful as an adjunctive tool.
It's not even just the stent size, it's the deployment pressure. So I was taught you don't deploy a stent generally before 14 atmospheres, and many times we're deploying at 20 or 24 atmospheres.
You know where that comes from, Brian?
You actually told me, so why don't you tell the stories?
So I was having a debate with this guy.
You weren't the one that taught me that, by the way. You told me the story. I want to be clear.
So I was having a debate with this guy, spirited debate on social media, because I don't have enough things to do during the day. And he reminded me that a lot of our technique was derived from a study done by Antonio Colombo in 1995. And the point of this study was back in the mid 90s for an intervention. It was all 8 French. It was all femoral. And these people were getting clopidogrel, aspirin, dipyridamole, and persantine, 4 anticoagulants, antiplatelet drugs. And Palmont shot stents originally. And he used IVUS to show if your stent was well expanded and well opposed, you didn't need all that anticoagulation. But he found there was a big difference between stents deployed at less than 14 atmospheres and more than 14 atmospheres. And also, there was this, I remember Brian said you used to want to see a step up into the stent and a step down. So you were oversizing it or oversizing your post-still balloons. And those patients were more likely to get perforations and dissections when if you did it, kind of matched the lumen size and just went to high pressure. So I know Brian does this. When I place stents, I usually do 16 or 18 atmospheres, 20 atmospheres every time, unless it's really close on size, and I'll come back with a non-compliant. And I hear people that push imaging and all this other stuff, and they're like, oh, I never deploy a stent more than 12. And then they come back with a non-compliant of the same size as 12 atmospheres. And I'm like, that's not, I don't think that's doing anything. So there were 2 trials released at ACC looking at IVUS. One was called Optimal and one was called IVUS CHIP. So Optimal was looking at use of IVUS for left main lesions. And then the other one was for complex PCI. And 2,000 patients. And basically it was a superiority trial. And neither one of those trials showed that IVUS guided PCI was superior. So I'm about to choke, so I'm going to get something to drink. So,
well, I heard
John will edit this out.
I heard one of the answers to that, Bill, was, well, of course, because those proceduralists were already experts in intracoronary imaging, so they knew what to do. But that's a circular argument. And
that's exactly.
I'm going to get some water. I'll be right back.
I just do on angiography, and that's how we were taught.
Brian and Aaron, what percentage of the time do you all use imaging, you think, in your practice?
I would say like 30 or 40. I don't know.
I would say probably 50, 60.
What do you think about the IVUS OCT combination now? I guess it's NePro and Gentuity. Is that right?
Well, I mean, the difference with OCT for our audience is essentially you have to inject during it, whereas IVUS you can slowly pull back regardless of injection, but the OCT image is much more lovely, shows you a lot more detail. The IVUS images actually can be pretty beautiful with the newer IVUS catheters and technology. In fact, Boston's imaging is actually very good when their current generation of catheter works. They're coming out with a new generation of catheter. But what they've spent on is their algorithm. So they've spent money on this device that essentially when you pull it through, it knows what the distal reference vessel is, how expanded the stent is. And their new thing is, and this is kind of scary to be frank, that you get a green light, where you get like a thumbs up, like, good job, doc, you're all done. Case closed. And the problem with that is you need to know how to do it without it, because you may be at a facility that doesn't have that. So you can't completely train on that. I have a colleague that definitely uses IVUS, I think, every case, and sometimes it's just petrified with decision making, and you have to make a decision and choose something. And so if you're from the, mid to distal LAD to the mid to proximal, yeah, you might pick a 2.5 stent that's really long, but you're going to post dilate the proximal end, but the distal end, you're not going to create a dissection due to the size you chose. And that stent can expand to that value, but to sit there, another thing they'll do is afterward in the post imaging, they'll say, well, it's not quite perfect. Now, angiographically, it looks perfect. Then they go to that next step and then a perfect. And it's like, you know what? This individual doesn't need perfect. They need better. This is, say, an 83-year-old person that has had this stenosis till they got to the cliff and now has these symptoms. They need to be better, not perfect. Because I will tell you, better is better than a perforation, tamponade, everything that comes with that, a hospital stay instead of going home the same day after PCI. I'm not suggesting performing suboptimal PCI. I'm suggesting that the way I was trained, if it angiographically looks excellent, that is probably just fine. Bill, you've said more extreme stuff than me, but I feel like I'm on the ledge now. Would you agree with that?
So let's look at some other things. So I think people that are completely guided by imaging tend to oversize more. And I'm still of the school of the shortest stent you need is the best. And that's because I trained before drug-eluting stents came along. So the less metal, the shorter the stent, the better. So I still do, the shorter stent, the better.
You popping in those 8 millimeters, lady?
Yeah. Not if that's the only one. No. If I need a whatever, the right size, and I put a couple of 8s, but I was overlapping them. That was this week now. I was overlapping them with something else.
Bill, there's actually the opposite of that sometimes. You talked about intracoronary nitroglycerin for decision. I've certainly seen stuff where things have come back and I'm like, hey, what is this? Well, why did you put this 2.5 in this proximal LAD?
Yeah, you see that in CTOs all the time.
They'll say, oh, I did OCT and, that was the size. I'm like, that's never the size of the proximal LAD. Or the left main. We had one, I was in the room and I was like, well, what's going on here? I was like, well, yeah, I imaged it. And I was like, it's currently thrombosed. Please put in a 3.5 balloon right now and balloon it. And the response was, no, I imaged it. I think, 3.0. It's like, this is the left main. Please do this now.
Yeah, I did a case.
That's by imaging.
Friday that, I didn't image it because it was left main and the latest trial said you can do good angiography.
You don't follow guidelines is what you're saying. You don't like...
I like guidelines either.
That's one of the guidelines.
But, angiographically, it looked tiny, but I ended up putting a 3.5 stent in there, to 18 atmospheres. And, so you can be misled by that. A couple of other thoughts is, again, people that are imaging zealots make you think that if you're not using imaging, you are habitually undersizing stents and underexpanding stents, and you're going to have these horrible outcomes. And my answer to that is the restenosis rate is single digits in the U.S. So I wouldn't call that an epidemic.
You be okay, Bill?
I was fine until we got on the thing.
What's the restenosis rate, Bill? Now
10%, 8%, 7%.
That's because of the drugs.
It's the drugs. We have good stents.
Yeah.
And the stent thrombosis rate is 1 or 2%. Here's another question for you, Brian. How much do they use imaging in Japan? Do you know?
I don't know the answer to this, but I'm going to assume every single time.
I think it's 95 to 98%.
Yeah, it's super high. Do the Japanese have a lot better outcomes in the U.S. where we only image less than 10%? Is their restenosis rate less? Is their thrombosis rate less? I don't think so.
So I was honored to have this guy here. He's fabulous, great guy. And they only have CSI in the coronaries in Japan, not in the periphery. But we were at my object-based lab, and he said, I want to ask you, how do you use CSI in the coronaries? And he said, well, they'll run it down, then they'll image. Then they'll run it down, then they'll image. They'll literally do it until they have the desired result and then stent. It's very different from the way we do things. But frankly, if everyone did it that way in the United States, nobody would ever get PCI because there aren't enough doctors or times or cath labs or whatever.
Yeah, maybe they're doing
What's
cases
that?
a day, 2 cases a day.
Yeah. Do you know the average time of their cases, Brian? I mean,
I was at
much
I
louder
was
than
at
I
a
guess.
conference there, and it was great. I loved it. Their live cases can run like hours, whereas we get like 20 minutes, to get in there and do what we got to do. And I understand we don't have to do the whole thing live, which we don't, but we try to. I'd love to do as much of the action live as we can, but much longer time getting cases, which to Bill's point, unless that is shown to actually improve the outcome, it doesn't matter. The other difference is the three of us that are interventionalists on this call follow up all of our patients lifetime, forever. That is what we do. It's very different from being in the lab and only in the lab. We're also general cardiologists while being interventional cardiologists.
Is that how Japan does it, Brian? Typically,
I don't know.
proceduralists mostly. I guess.
So I've heard that argument too. When I say, we're in restenosis trials and it's hard to find people with restenosis. And they're like, oh, they're going to other hospitals. I'm like,
Oh no, they're not. We're in a county. We're in a
so
county.
maybe in New York, but not in Tallahassee and not in Spartanburg. So let's talk about OCT.
That's a great
Nana.
answer.
Todd knows OCT and Brian likes it. We're getting it. One of the things I'm a little concerned about, and you alluded to it. What are you laughing at? It's this AI stuff, right? So this AI stuff, with the OCT, where it's going to tell you where's the calcium. It's going to say you need to do CSI right here in this spot where there's this, and then you need a stent this diameter and this length. Ready to go. And I think I'm afraid that's going to be what happens. Is that a bad thing? I think it might be, because we all remember Skynet.
That's it.
Where that ended up.
More efficient and lead to better outcomes, both. Then yes, it's a bad thing, or a good thing, I guess. But it has to do those things. It has to be more efficient. It has to show a better outcome. Otherwise, it's just selling products.
And I think there is a huge marketing aspect to this. I looked up for the Philips site in Boston. I'm going to tag every imaging company on this episode. I'm going to tag them all. Nipro, our friends at Nipro, I'm going to tag them all. Because they need to hear this. I think there is a huge marketing aspect to this, because these companies want to sell catheters. So they want to make you think, the term is contemporary PCI. You're not doing contemporary PCI if you're not imaging all the time. That's it.
What year did that start? We got to define the year contemporary PCI started.
2 years ago.
Okay, well, I have a question. So, everyone on this episode, you're high volume interventionalists. You do it a lot. What about the physician that's doing, I don't know, small number of PCIs a year that doesn't get the times at bat that you get? Is that a great tool for this person? Or
that's what the company's all trying to make the point, that we're going to make it easy for everyone to do a great job. That is the point. And that is not necessarily bad. Like, I would like everyone to do a great job. Great job's a little bit in the eye of the beholder, but still, I see your point, Todd. I've heard that point. Bill, what do you think about that? No, Aaron, what do you think about that?
Yeah, Aaron.
No, I agree with you guys. There's a slippery slope with this AI business. It creates way too much AI dependence. You see it all the time in kids nowadays. Everyone's relying on Claude or Chat GPT to do every work, and it's taken away just using your own brain. That dependence, I think, is going to foster a lot of inept trainees, down the road that are going to be completely paralyzed if they don't have that crutch. And so I do think that that's a dangerous direction that we're headed in.
so you just resist
What?
AI. I mean, I was in Boston today, Aaron, talking to another.
I don't even do TikTok, John. I'm not doing AI.
That is, he's close to your age or a little bit older, maybe, but he was saying the exact same comments about AI. And I was talking about, is the pressure wire going away? because of these new angio-derived FFR.
Oh, he's so much responsive.
Sir,
I love pressure
So-
wires.
It works.
Yeah.
No, finish your point, Todd.
well, no, to his exact comments, Aaron, were exactly what you said. He said, I'm a little weary of all this AI stuff. It's scary to me. I think it's trying to dumb things down. And this was at a academic institution too, which is great to hear that he has those thoughts. He's just said, I'm weary about all this AI stuff.
I think AI is going to recommend atherectomy. That's what I swear to God. I swear. That's what's going to happen for Abbott. OCT is going to suggest orbital atherectomy, and for Boston, it's going to suggest rotational atherectomy or consider. It won't recommend it. It'll say consider. Now I see cases posted, and the very first step is, well, the IVUS wouldn't pass. All right, so now what? Like, well, what happens when the IVUS doesn't pass? Are you going to know what to
What
do?
size balloon do we use?
Right. Right.
So,
Well,
where
do you
I draw
think
the line
other
could be-
specialties, Brian?
What?
I'm curious, real quick. This is a really interesting topic, this AI thing, and hearing what Aaron said, and that I heard this today in Boston. Are you hearing from your colleagues in other specialties that they're having? I mean, I think it's a global systemic problem, probably, for training most proceduralists now, and it's scary to think that AI is going to try to simplify and dumb it down so much that people get out and don't really know how to do it. It's crazy.
I mean, realistically, things take
Am I being dramatic, Brian?
No, I say things take a long time to roll out. Like literally, Bill, the words that just came out of his mouth were, "We're gonna be getting OCT soon." Like I used it first, like 15, 16, 17 years ago. I mean, it's a long.
Well, it wasn't very good back then. Gotten
You
better.
had to have a syringe, like a 100 milliliters to push in there. But anyways,
And it's expensive.
things take a while to proliferate. Where they don't take a while is on social media and at places that are hooked up with these people. So to look,
Good point.
just like Bill and I are looking at these cases, and people are like, yep, 40 hemispheres and down, this is it, fully expanded. And like, whoa, like I'm not necessarily scared by the hemispheres, but that is rarely needed. Like, what are we talking about here? Things expand.
Yeah, and I think it's Brian and I and Aaron's responsibility to police the internet and call BS.
You're doing a good
There's
job.
there is so much BS out there. I have to restrain myself.
We need to start I know this isn't going to be probably great for us, or maybe the greatest. for us.
Oh, no.
I know where you're going. Showing the posts, be like, do you just want that statue cut out? Start ballooning it, and it just went like this. And then it's
I'm like, that guy's never done that in a patient. And then, one guy, he did like 30 lines of what he did, and each line had a different emoji. I don't know, there were 30 emojis to begin with, but every line was a different emoji. And I asked him, what took longer, the case or the post? I mean, which one to draw?
No, he used ChatGPT to do the post. So it's okay.
Oh, maybe that's what they're doing. And then one guy, I just responded with a picture of the Oscar award because it was so dramatic. It's like the mood was tense, the night was hot. I mean, it was stupid. So people are posting unrestrained. It's just like anybody can post anything, and they're doing crazy stuff and making stuff up, and it's just ridiculous. It's entertaining.
Call them healthcare heroes.
Yeah, it's ridiculous.
Hey,
All right.
Al.
All right, so OCT. So we alluded to drug-coated balloons. So there's this big push not to leave stents behind. I'm going to put stents. If you take care of me, Brian, just put a stent in. It'll stay open forever, as long as it's high pressure. You got it.
direct slide a little longer.
So I want the best imaging possible. If I'm not needing a stent, I think OCT gives you better pictures. It's got its own issues, but so back to the trial for a second. Brian mentioned, they said the reason the angiography arm did so well is because the people doing that learned their angiography from IVUS. So they were IVUS operators, and that was guiding, and that's such bullshit.
Wait, they were IVUS operators first and then learned to angio?
Well, they're so good without IVUS because they know what IVUS shows them usually. So they operate as if they're using IVUS, but they're not. That was the
It's
explanation.
like someone that was trained on angiography. It's weird.
Right. So one thing is you can do good angiography. You can do great.
Dude, you know how much bad angiography there is out there? Like, it's crazy to me. Like, you set up the scene, you inject, you step on the pedal, you inject, and then you wait, and then you wait, and then you're done. I see people that are moving the table nonstop during angiography and then not waiting till it's done. And it's like, what is this? What are we looking at?
Have a universal view of the right where one of my old attendings, you know, when we shot the right, he would pretty much go from LAO to crane to RAO.
The 90. Did you go to the 90 RAO?
It was fantastic.
Yeah, that's one thing, but I'm just talking about, they're not getting another angle. I'm talking about they weren't centered on the vessel and are just moving around trying to chase the contrast around it. Yes. And then they don't wait till you can see the collaterals. And it's like, what are we doing?
So, you know, inexperienced operators, I think imaging absolutely helps when you're trying to learn vessel size. How do you learn vessel size? Doing tons of cases. I almost always undersize my pre-dil balloon because I'm not trying to make it 1-to-1. I'm just trying to make room for a stent. And I could tell, wow, it's way undersized, or it's a little undersized, or that's pretty good. Bad operators are probably going to be bad no matter how they do it. And good operators are going to be good no matter how they do it. So it's a tool, but I don't think it's mandatory that you IVUS. And I think people need to get off the high horse a little bit. And if somebody's a good operator, they're a good operator, and acknowledge that. And if they don't image routinely, so what? You know?
Bill, do you get a lot of grief about that? Do you get the question a lot, or is it mostly from industry, or is it from your?
I get it from I get it, you know, industry, like, do you image much? No. You know, but anytime you go to an academic place, or you go to a place where there's a lot of academic people, that's like, it's a religion. So that's what the title of this is. Intracoronary imaging. Is it reality or religion? I think for some people it's religion. I absolutely do. And that's what I push back against, is the dogma, and what word to use, the fundamentalist view that if you're not imaging, there's no possible way you can be doing good work. And I think that's crap. And hopefully these last 2 trials at ACC proved that they were good trials. You know, you can debate it, whatever, but 2,000 patients in one of them. And, you know, I was vindicated. I was vindicated for years of abuse. So.
Jordy, you're just listening here, smiling, enjoying all this. From an outsider that's new to industry.
And I'm all called it out. I haven't even been drinking. So.
What do you think about this lively discussion?
Well, I mean, you can just hear the difference in generations, difference in the approach. I guess it goes back to the teaching. Is that the evolution of the teaching, or, you know, to hear you guys talk about it, it sounds like a great debate, but one that you all believe in.
Yes.
Yeah, I think Aaron said he's at 60% imaging. Brian, you said about 50, and Bill 10. So
Yeah.
It is interesting to have a 20-year span with Brian right in the middle, and just to see I guess.
So I use stretching wires.
30 to 40. 50 is a little rich for me.
Yeah.
Sorry, Brian.
But
I didn't mean to get you wrong.
But I believe in science. So physiology, so that's pressure wire. I use that all the time. I think there's great science for that. But I don't tell people they're hacks if they don't use pressure wires. You know, you do it your way, I'll do it my way. And if we both have good outcomes, then the patients are all the better.
Do you want to spend a minute or two real quick at the end? Todd asked that question about does intracoronary live physiology replace the FFR wire? And my reply was CT-FFR is already doing that. But
You believe that?
Well, what we're finding as many times is that we have to re-FFR while we're doing it or re-image.
So the answer is no. So some of my latest arguments is this CT guy who thinks CT and photon, whatever. So now what we use, and we were in a trial, we did over 100 patients, is the CathWorks, the angio FFR. Have you guys seen that?
Yeah, Medtronic
So
acquired.
are you popping in a 2.0 stent and a distal PDA based on the CathWorks?
No, I don't. So they don't use it. We don't use it for size. We use it for is it obstructive or not.
I know. I meant how distal it was when the FFR shows 0.73 and like a mid PDA.
So basically, I use it to confirm that I was right. So, it's obstructive or not obstructive? So I think it's helpful if it's you got RCA and circ disease and the LAD, you're not sure 50, 60, whatever, and do the CathWorks and it's non-invasive and you don't have to put a wire up. And actually the first 5 or 10 I did a pressure wire, also an invasive, and the one time they didn't agree, the pressure wire was wrong. So I feel fairly confident, and I feel a lot more confident in that than I do CT-FFR.
Do you, for CathWorks, do you have to give intracoronary nitro?
No. They just do it off the angiogram. I had to talk.
When you do your actual FFR wire, the physical, the old ready wire,
yeah.
What do you inject? What do you give systemically? What is your?
I don't inject very often. If I do, I give intracoronary adenosine. But we use, I guess, for Boston, the common wire is called DFR. So they basically gate it to the EKG, so it's instantaneous. Now, if it's really borderline, then you can switch it to true FFR and give adenosine. So I give intracoronary adenosine.
What's your dose for the LAD?
30. No, yeah, 30. 30 or 100. I can't remember. It's 100. I think it's 100.
Very hard to see it in the 100.
I haven't given it in a while.
Really, all I wanted to hear was that you don't give it systemically because people feel terrible during systemic adenosine. So.
Dude, were you still training when we did the adenosine stress test?
I mean, they do them for nukes. What do you mean?
So Lexiscan replaced adenosine, and before that was dipyridamole or Santine. So adenosine, if I gave you a slug of adenosine, Jordy or Todd, you would think you were dying for about 5 seconds. You would flush. You couldn't breathe, your chest would hurt. Well, for the stress test, we would have to pump it in for 4 to 6 minutes continuously. And the patients, I can't breathe, you're fine. Oh, my chest hurts, oh, my head's gonna explode. No, you're fine. So anybody that has had that test refuses to ever have another stress test like that. They'll say, oh yeah, I'm not doing that again. So, but no, there's no reason to give systemic adenosine for that. You get intracoronary.
Frankly, I see it with regadenoson too. I've got a bunch of patients that I'm repeating nukes on, and they all have regadenoson.
And I've learned you can't give that to people with seizures. They'll have a seizure or are on seizure medicines. So, all right. And parting thoughts, Aaron. We appreciate you coming on.
Thanks for having me.
Thanks for keeping Brian as straight as possible.
That's impossible.
We got it. Oh, you look good in that scrub hat too. So,
gotta rep the blue.
Wait, this is Blue Collar ICs, so we need some sort of thing here to induct Aaron as a fellow Blue Collar IC.
Yeah. You need to pour a bucket of water on you or something.
That shotgun of beer.
Gatorade.
Yes.
Get the Gatorade.
Yeah, usually if we have somebody in the lab and it's their first case, I'll tell them they have to drink blood and like shooting you, like show me deer. So,
Hey, Aaron, I'll ship you a trucker hat, Aaron. So,
Dude, I appreciate that. Any merch you got, I'll take it.
all right, you want to take us out, Jordy?
Shirts too.
Another great episode. We appreciate everybody for joining us here. Aaron, as the boys said, thank you very much and appreciate your time this evening. Looking forward to our next episode. Until then, make sure and subscribe on all social media and all platforms. Of course, the YouTube channel, continuously growing. You can watch us here each episode every week. Go back and watch episodes. Shout out to our producer, John. He's doing a great job behind the scenes of kind of keeping us up to speed and making sure that we're in all the places that we need to be. So, great episode this week. Aaron, thanks again. Go Tigers on the way out. We'll talk to you next week.
You've been listening to Blue Collar ICs, real conversations from the front lines of interventional cardiology. Special thanks to hosts Jordy Culotta, Bill Dixon, Brian Brown, and Todd Flor for sharing their insight, experience, and perspective. If you enjoyed this episode, subscribe, rate, and share the show. Join us next time for more real-world cardiology, only on Blue Collar ICs. Blue Collar ICs is a production of the RealWorks Media Network, Tallahassee, Florida,